Okay, good afternoon, guys. I think we'll begin. Um, the person who was supposed to speak with me, Dr. Kurlmeyer, is enjoying spring break and sends her regrets to all of you that she couldn't make it today. And, okay. However, I am going to do my part. But I have good news. I have a surprise guest speaker for y'all. And so they'll be making their entrance. Don't read the screen. I don't want you to know who it is. And so they're going to, fill in the CT portion. Since it's only us, please feel free to ask me questions as we go along, and we'll just make it interactive. Otherwise, I'm not going to make this too long. So when it comes to, we've all seen masses by transthoracic echocardiography, and it's a common thing that we as clinicians have to figure out, is what we're seeing real? Could this be a thrombus, or is this a tumor? And, transthoracic echocardiography, is really the first-line test when it comes to assessment of masses in the heart. But, it has its issues. We don't necessarily see all portions of the heart well. You really don't you have a limited field of view. You cannot see really anything outside of the heart, and it does a really poor job of soft tissue characterization. So hence, advanced cardiac imaging, things like CT and cardiac MRI. And as you know, these techniques have some significant strengths, which can be very much complementary to echocardiography. And in particular, some of their strengths include having a large field of view, having a versatility of imaging multiple different planes that you would choose, having very high spatial resolution, and specifically for MRI, having very high tissue contrast. So, both these two techniques, CT and MR, I believe provide incremental value to echocardiography. They can help you identify and contribute to a differential diagnosis of what a cardiac mass is. It can help detail relationships of the mass to both cardiac and extracardiac structures. It can help in the planning of therapy, be it surgery or chemotherapy. And then once the patients have some intervention done, they can be very helpful in monitoring for tumor regression with your particular therapy. So this is just a reminder that these techniques, and as we go along with my slides, I hope you agree that both CT and cardiac MRI are really, by the appropriateness guidelines, given a recommendation A for the evaluation of cardiac masses. So let's just move directly on. So cardiac MRI, y'all have all seen these images. But what are the particular strengths of this technique in particular? Again, you have the very large field of view. You have free choice of imaging planes. You have a very high spatial and temporal resolution. You have a high contrast resolution. And really, when it comes to the assessment of cardiac masses in particular, it's really the only test that has the best tissue characterization. And that's really where I'm going to spend a lot of my time on this talk. So when it comes to tissue characterization, what is CMR capable of, and how can it help us? And CMR can help us in several ways. Number one, it can help us before contrast and the contrast images themselves. So the pre-contrast images, we have two different types of sequences. We have what are called T1 weighted sequences, and we'll discuss a little bit about these different sequences in the next few slides. But T1 weighted sequences really help assess, whether there's fat, whether the object that you're seeing is fat or acute blood. Your T2 weighted sequences are really your water sequences, or really here where, if you see if the image is bright in a T2 sequence, it's indicative of edema. And then the other way CMR is helpful is on your contrast-enhanced images. And there's a couple of different sequences that we use post-contrast. These include a dynamic first-pass rest perfusion, which tells us vascularity of a mass. There's the delayed hyperenhancement images, which tell us a little bit about fibrosis and vascularity of the mass as well. And then our long TI images, which can be very, very helpful when it comes specifically for thrombus imaging. And it's really these techniques in summation that really, are the workhorse with CMR and cardiac tumors. So what is a typical protocol we use in cardiac MRI for when it comes to patients with cardiac masses? Well, a little bit of just what we described. We'll start off with our functional cine SSFP images. These are the images that, show very high contrast and spatial resolution of the heart. You can image in any plane. You can see what effect the mass is having upon the myocardium. We'll then do a structural assessment of the heart with some pre-contrast sequences, which include, again, the T1s and T2s, remember. And then once those are completed, the patient will receive contrast. And here's where we will then do a rest perfusion study where we look for vascularity, and then go on to our delayed hyperenhancement and long TI images sequences. And you'll be seeing these slides, each of these sequences in the following slides. Okay, no, that's a great question. So hopefully in the next few slides, I will show you the worth of each of these particular sequences when it comes to an assessment of a mass. So hopefully you'll leave with the understanding that, yes, I think in a CMR protocol, it's very important to have all of these features. But in general, normally in a classic, let's say there's not a cardiac mass there. So, I should temper that by saying that, that's one of the strengths about CMR is that there are, depending on the indication of the study, there are so many different sequences that you have an option to do that you really can't run. It's not necessarily running the same set of sequences for each patient. It's rather running particular sequences for a particular indication to answer a particular question. So, to answer your question, I would, if at your institution, they're not doing a lot of this, I would recommend at a basic level, at least, the SSFP images, which gives you a gross morphology of the heart and the mass. T1 and T2s are very helpful. And then some assessment of whether contrast is taken up in this mass. And with either rest perfusion or delayed hyperenhancement, preferably delayed hyperenhancement. And then those are standard sequences when it comes to, general function viability protocol. And you'll see why that's important for masses as well. So just going into the SSFP images, again, if I haven't mentioned it, we take our general protocol is to image the heart from base to apex. Then we do just our standard echo long axis views. And then we can actually chase the mass as well. Whatever mass is seen, you can create whatever imaging plane you would like to image to see the mass in its entirety. And at the same time, these images can be very helpful in seeing the effect of the mass to the surrounding structures, and especially for cardiac function. When it comes to a structural assessment, pre-contrast structural assessment, this is where T1 and T2 imaging is very important. So I will try my best to explain T1 and T2. Hopefully y'all remember a lot of it from Dr. Shah's lecture. But basically, all elements based on their proton configuration have inherent T1 and T2 values, which are different from each other. And we can create sequences. There are sequences with CMR that are T1 weighted to bring out these T2 weighted effects of these elements. Or there's T2 weighted sequences which can break out their particular T2 effects. And if we take a look at this graph, and let's just focus on fat in particular, you can see, and this is just let's say for fat on your T1 weighted images, this is a curve of time versus magnetization. T1 is really when it's your rate of longitudinal recovery. So you've tipped your protons to 90 degrees, and you're seeing, how quickly they recover in the z-axis or in the longitudinal plane. Now, from this graph, you learn that different elements have different rates of recovery. So fat has the shortest T1 time. It recovers very, very quickly, whereas myocardium has an intermediate value, and water has the slowest recovery. Similarly, T2 is a little bit different, is once you've tipped the protons 90 degrees, T2 looks at the dephasing of the proton in the XY plane. And so here in this particular sequence, you can see from what I've traced where fat, again, has a very short T2. So it has a short T1 and a short T2. So it tends to dephase rather quickly when you compare it to something such as myocardium or water. And water, again, having a very long T2. So how does this help us in images? Well, you can imagine if we had a cardiac mass and we created particular T1 and T2 weighted sequences, these fat would look different in whether the sequence was weighted on a T1 setting or weighted on a T2 setting. For example, and this is just a good example of this, yes, we know just by looking at the cine images, you see these two dumbbells that this is most likely lipomatous hypertrophy of the heart. But CMR can then take it one step further to confirm, where you can actually interrogate the tissue characteristics, the properties of that tissue itself. And if you look on the T1 weighted images, remember T1, as shown here, fat would have a very bright signal, and that's exactly what you see on the T1 weighted images. And whereas when it comes to T2 imaging, remember T2 had a short T2. And therefore, if we go back to these particular images, the magnetization vector of it would be the smallest. It would appear dark in those images. And when you apply, if you have our T2 weighted sequences with fat saturation, the fat itself appears dark. So this is how you can use different sequences to really interrogate the intrinsic composition of the mass that you are seeing. Similarly, if we look at water, and we've kind of mentioned this, water has a very long T1. And if you look at its magnetization, you would expect the image on a T1 weighted image to be much darker than what you would see for fat. And similarly, on the T2 weighted images, you can see water has a very long T2. And if you look at the magnetization values, you would expect it to have a brighter signal on T2 weighted images than you would a fat. So a very classic example of that would be something like a pericardial cyst. And you can see this large cyst usually originates from the right costophrenic angle. It's compressing the right atrium. And if we look at the T1 weighted images, this time it's completely opposite from what we saw from the fat. The image is dark on the T1 weighted image, whereas on the T2 with fat saturation, you see a very bright image. So this goes along with, some structure that has a composition of water, or in this particular case, that goes along very well with pericardial cyst. The next, once you have done our pre-contrast techniques to help evaluate a mass, then we go ahead and give contrast, and then we have three particular imaging sets here. One is first pass resting perfusion, which helps you evaluate vascularity. And this is just an example of something where you see a mass at the apex of the heart, but you don't see significant contrast uptake. Compare that round dark dot to the myocardium, which is full of contrast. contrast this with this mass here that's right above the right pulmonary artery. And you can see it's dark initially. As soon as you see the right side of the right atrium, right ventricle, right RV outflow tract light up, this mass lights up in similar proportion to what you see on the right side. So this would be an example of something that was very, very vascular. All right? And then finally, delayed hyperenhancement imaging. Dr. Shah has gone over this in our earlier talks. This is, y'all are used to this in the setting of looking for scar, for viability. And the concept here is whenever you have living, normal, healthy myocytes, gadolinium is a extracellular, extravascular agent. So wherever you have normal, healthy myocytes in a pixel, you know, there's really no room for gadolinium to accumulate. Whereas in the setting of an acute infarction or where you have tremendous scar, where you do not have living myocytes, gadolinium now has a chance to fill that space in a particular pixel. But the basic idea here is that, you know, tumors and masses, they cause necrosis of the myocardium, they cause inflammation in the heart. So these would be areas where you would expect some contrast uptake of the mass itself. Yeah, this would become very important. We prefer to because it will help us to differentiate thrombus from mass, from a tumor. Well, yes, they have different characteristics, but those characteristics are based on giving contrast agents. Is a problem. Correct. And hopefully these next few slides will get in, you'll understand the concept a little bit better as well. So when it comes to scar imaging, as you know, we use an inversion recovery sequence, and the concept is straightforward. You want to create an image. You've now tipped your protons 180 degrees, and you image, and as the T1 properties of your heart, as time goes along, the T1 properties of the heart, you image at a time point where the net magnetization of the myocardium is 0. So the myocardium appears dark. Now, because anything that has taken up gadolinium is a T1 shortening agent, anything that has taken up gadolinium will therefore appear as a bright image in your sequence where the myocardium is black. So you just create a time point where you image where the myocardium is dark. Because whatever object has taken up gadolinium, it has shortened the T1. If it has shortened the T1, it will appear brighter than what the myocardium will appear on these images. And so this is really the basics of scar imaging. That's why normal myocardium appears black and scar tissue appears white. And this is just an example of that. That, you know, here was a cardiac mass. You know, when we do our delayed hyperenhancement imaging, you can see that, you know, there is evidence of contrast uptake or gadolinium uptake in this mass here on the anterior of the anterior to the anterior wall. Now, we can take this logic a little bit further and see how we use it to look for thrombus imaging. The basic premises of a thrombus is that it is a substance that takes up no gadolinium, that it does not perfuse at all. So it will have a very long T1. So using these particular sequences, we can find a time point much longer than our traditional delayed hyperenhancement images, where thrombus will appear black, but myocardium and anything that has taken up contrast will appear bright. And this is really the concept behind what is known as long TI imaging, which specifically probes for thrombus. And again, if to try to say this better is, the basic concept is gadolinium. Thrombus does not take gadolinium, therefore, it will have a very long T1. You can image at time points that have you can image at a very long inversion time to where even the healthy normal myocardium and anything that has taken up contrast will appear white, to create this very stark contrast between a thrombus, which would appear jet black, as in this image, or any other tissue which would by then have taken up contrast. So what is the role of CMR? How can you use these sequences then to help figure things out? So I think, the first thing is to figure out, well, the object we're seeing, is it a tumor or is it a pseudotumor? So as you know, there are a lot of benign findings on echocardiography, and as good echocardiographers, we have to make sure that we don't misinterpret as pathologies. For example, here is an image where you see a possible mass in the right atrium. This patient also had a stroke, was elderly, and therefore was referred for further imaging. Here's corresponding CMR, and I hope you all would appreciate this was not a pathologic mass, rather this was what we call a very prominent crista terminalis. Another way it can be helpful here was a patient who was admitted with epigastric pain, and in the left atrium there was, a question whether we were seeing a large mass. Here's the corresponding CMR images, and as you can see, other than an atrial septal aneurysm, we really don't appreciate any mass. But if you look at the bright bloods through the chest, you can see that this patient had a very large hiatal hernia. So really on the transthoracic imaging, it was with the beating heart, there was just this hiatal hernia was coming into view in the particular four-chamber plane that you were imaging. Here, this case, I think most of us are very in tuned to identifying lipomatous hypertrophy, but again, this is just, we lump this into the tumor versus pseudotumor category here, that really with tissue characteristics with CMR, you can very easily figure it out if you had difficulty on your echocardiogram. And same with the pericardial cyst. So this was an interesting case we actually saw here. This was a patient who was referred for surgical removal of a new left atrial mass that was found on a post-op TEE, and the patient had just undergone a two-vessel bypass. So this would have been a really tragic episode, that this patient would have to have their chest split open, and the fact that this may potentially have been missed preoperatively. And here are the CMR images, and I hope you appreciate this very large mass in the right AV groove. Now, if we look at T1 and T2, really, on T1 images, it appears dark, as well as on T2 images. And if we look at our first pass perfusion, you can see the blush of contrast now on the left-hand side. It really does not take up any significant amount of contrast. And on delayed hyperenhancement, this is a very particular pattern where you see darkness in the middle, and you see this rim of hyperenhancement. And this has a very pathological, this is a pathognomonic description of what this is. But, this was simply, we wanted to confirm our findings. We sent this patient for a non-contrast CT, and some of y'all who may have already been tuned to the diagnosis are absolutely correct that this was just really a case of severe caseating mitoannular calcification. And if we go back and actually review the transthoracic echocardiogram that was done at the original institution, you can kind of you can see this large mass in the AV groove that even then, should have been identified as bad MAC. All right, so the next step, how can cardiac MRI help us? Now, once you've identified whether the lesion you're seeing is tumor or is it pseudotumor, is then to figure out, well, is this thrombus or not? And so here we have at the apex of this heart, you see a mass, you've given echo contrast, and you can see that there's a filling defect in the apex of the heart. If we look at the CMR images, you can see very nicely, and these are all now our long TI images. Remember where we're imaging at a time point where only thrombus will be black. Everything else, including scar tissue and myocardium, will appear brighter. And here I think you can very, very clearly see that there was a clot at the apex of the heart. But what was interesting was what you saw in these images as well, is on the two-chamber, you also see a laminar clot in the anterior wall as well. So just a little bit about how sensitive is contrast-enhanced MRI. This was a study that looked in 160 patients with ischemic heart disease who had both transthoracic, transesophageal, and CMR within 30 days of LV reconstruction surgery. So you had actual pathological confirmation for the presence or absence of thrombus. And in this particular series, thrombus was present in about 30% of patients. And here you can see the sensitivity and specificity for MRI really was exceptional compared to the echocardiography techniques. Now, granted, in this technique, for sure, I don't think it's this bad for echo, the sensitivity anyways. This study was done without echo contrast. This was just a study that they looked at as prognostically, what does CMR identified as what we think is thrombus, what does that prognostically mean? So this was a registry of about 784 patients who had LV systolic function, and they were followed up for 6 months for stroke or TIA symptoms and or pathology. Of those, about 243 had both echo and CMR, and about 216 of those patients had 6-month follow-up. And so of these 216 patients, when you looked at the delayed hyperenhancement findings, 24 of them were identified to have thrombus, of which 16.7 had a clinical event or some pathological validation. Whereas if we said thrombus was negative, you can see only 3.1% had a clinical event or pathological validation. Compare this to echocardiography, whereas if they identified a possible thrombus, clinical events or pathological validation was significantly lower and really no different compared to whether they said there was thrombus, whether... No, I don't. Yeah. What was the quality of the clinical events?
I mean, we cannot be doing EMI in every patient with an acute mass. So if you miss a zone, which you will, what's the real bad outcome that you may have to do? I do not really like that they do pathology. That was trying to fix their mechanism. But the article probably doesn't have the events. In fairness to them, I'm sure there's a table.
Yeah, I can definitely find out. Yeah. Mickey Mouse. Yeah, I agree. I will definitely get that. And this was another. This was another.
You go for an article coming up with that image on the same topic, and I wrote a report for it, but a little bit more knowledge about these things, and the big issue is, what is the clinical significance of this? Nationwide, even if we do echo, we have the acute MI, by the way, we don't have it. So even if we did, kudos to me. And the question is, how much harm are you doing by missing it? That's what we do.
This was another study. This was a mixed cohort of heart failure and post-MI patients, about 121 of them. And here, non-contrast echo, contrast echo, and cine-CMR were all compared as to their ability to detect thrombus. And here, the thrombus rate in these studies, with using CMR as a gold standard, was about 20%. And I think similar to the other study, we see a low sensitivity for non-contrast echo techniques, which are significantly improved with contrast echo, but at least here in this one particular study, still not as good as cine-CMR. So, what are some other features that can be, this was, and in this particular study, they went and specifically tried to evaluate, which were the thrombi that were missed by echocardiography and picked up by CMR. And in this study, they identified, obviously, the smaller the size of the thrombus, that was more likely to be missed. And the ones that I think we have examples of in our own lab are what are these mural or laminated thrombi, where they can be just, take the particular shape of the LV wall. And so what you think is the LV wall or an akinetic segment really turns out to be a laminated clot. And then, of course, let's not forget, just like echocardiography, CMR can be very helpful in identifying structural risk factors that predispose to clot. Our guest speaker has arrived. Dr. Chang is our special guest speaker for today. What do you call it? Obviously, patients who have ejection fractions that are significantly depressed have a higher risk, and those who have increasing severities of dyskinetic and akinetic segments, as well as segments with greater than 50% transmural scar. And you can see the relationship between transmural scar and wall motion abnormalities. The more scarring you have, the more disconnect the segment, the more predisposition you have for thrombus formation. Now, when it comes to figuring out whether your mass is a tumor or not, right now we have one large publication, a second one publication, hopefully pending. If Dr. Cassie is in the crowd, she's supposed to help us get this out. But this was a study of about 116 patients. 84 people had thrombi, 17 had benign tumors, and 25 had malignant tumors. And so when they looked at criteria to help differentiate tumors and thrombi, what they found were, thrombi, of course, morphologically tended to be smaller, more homogeneous, less mobile. But when it came specifically to tissue characteristics, what they found was tumors were hyperintense compared to myocardium on T2. Remember, T2 was edema imaging or water imaging, so that these obviously, tumors have some edema in them, and that they all had presence of contrast uptake. And those could be detected by some of the sequences that I had mentioned, either first pass res perfusion, late gadolinium enhancement, or long TI imaging. So anytime, I think the key point to learn, and I believe I have a slide for this, and hopefully to answer Dr. Q's question as well, is when contrast, if you have a mass and contrast is taken up, that is an indication of tumor. I'm not saying benign or malignant, but I am saying tumor. And this is just an example of that. Here on the right-hand side, you have a mass at the apex of the heart. On first pass perfusion and late gadolinium enhancement, you have no contrast uptake. This would go along with a thrombus. Whereas on the right-hand side of the screen, you have a mass at the apex of the heart. You can see that it perfuses on first pass perfusion, and on late gadolinium enhancement, you see darkness with a lot of heterogeneity of brightness in the mass itself. And that is indicative of gadolinium uptake or scarring, inflammation, collagen, whatever you want, but gadolinium within the presence of the mass. So this is just going back to our thrombus. Okay, this is again just driving home the point if I didn't drive it in. that, when it comes, even with anytime you have thrombus will never take up contrast. Very helpful. It'll always appear dark on our long TI and late gadolinium enhanced images, whereas tumors will take up contrast in our late gadolinium and long TI imaging. So here's a case. This was a 52-year-old diabetic, mitral valve replacement in 2009, chronic AFib on anticoagulation. I think we saw a recent case like this too, I think in Valve Conference. Normal EF, admitted with diastolic heart failure, and you see a lot of different things floating around in the right atrium. So this is just an example on T1 and T2 that has similar tissue characteristics as the myocardium. And if we look at now giving contrast to see whether contrast is taken up, if we look at our first pass perfusion, I think we'd all agree that there doesn't seem to be any evidence of contrast uptake within these masses. And if we perform our long TI imaging, which is really just sequences where we're looking to see whether there's any uptake of contrast, these images appear jet black, meaning there's been no evidence of contrast uptake, which here in these images would appear bright or white. So our diagnosis of this was thrombus, and this was confirmed by surgery. And this is just an example of a laminated thrombus here in the anterior wall that you see on the cine SSFP images. You do the post-contrast CMR with long TI images, and it really, you're creating different, you're interrogating the myocardium for specific tissue characteristics. So you can really now appreciate the clot compared to the surrounding myocardium.
I don't know if you have joined this case, but we had a case a few months ago. The dogma is if you have a mass attached to a segment that contracts, you cannot do it. That dogma. So we had a case that it kind of looked like a clot, but the whole ventricle was blue. And the patient had a big mass, one of the letters in the and it was a clot, and there was just the tip of the agent that was taken in. And the echo just missed it because of the issue of obstruction. So I think that's the one case that broke the rule in parentheses that a clot is attached to an epithelium, but it didn't because in fact it was. But it's a great case. You may want to find it and put it in your file.
Sure. Yeah.
Because A, it proves the point that even that all clots are attached to the epithelial section. But second, also, there's not necessarily a relation between the size of the epithelial section and the contact. And the pathophysiology of the clot are still very interesting. Because you may have large apical impacts, not clots, and you may have relatively small apical impacts, but they know that. So the whole pathophysiology of what creates the thrombus is still out for a lot of more. That's a great case. You can find it.
I will.
You will enjoy showing it because you enjoy the echo of missing it. I'm not missing it, showing it, but not showing anything else. And then you have
And the clot extended backwards.
and then the clot is attached there, and of course you can see it in the area.
Interesting. Yeah. This particular case just showing you that with anticoagulation that those findings resolved. And then finally, when it comes to distinguishing benign versus malignant, this is, similar to echocardiography, we have to use secondary clues. Obviously, the larger things are, the more irregular defined the borders are, the more invasive they are. The chances that if you have surrounding pericardial and pleural effusions, you'll have to look at the lung fields to see if you see any nodularity in the lung fields. If you see multiple lesions, these are all just secondary clues that this is more than likely a malignant process. There are tissue characteristics here, and really those tissue characteristics are that you would see edema, so you would see brightness on T2 imaging, and then again you would see some sort of contrast uptake demonstrating vascularity. But if we go back to that data, the 116 patient data where they actually looked at how to differentiate benign versus malignant, what they found, as we thought, was malignant tumors generally were larger and again more frequently exhibited first pass perfusion and late gadolinium enhancement. But if you actually look at the diagnostic accuracy, it's really total overall diagnostic accuracy to differentiate benign versus malignant is moderate at best. So really, I mean, this goes to show you that, both benign and malignant have overlapping features, and that's really where, tissue diagnosis, further attempts to obtain tissue can help in making the final determination. And then I think what CMR is very helpful is generating a differential diagnosis for a tumor. So just these are my last few slides because we do want to give Dr. Chang a chance too. But, we have now multiple tables which, based on how things appear on T1, T2 weighted images, how they appear after contrast, there are particular combinations. You can kind of get a good feeling of, what we're looking at. In general, or at least help generate a differential diagnosis. But again, main point of this slide also is that notice that whenever something does not take up contrast, we can definitely very clearly identify what those things are. Either they're fat, they're thrombus, or it's some cystic structure. So just a quick this is, I think, I'll spare this for the sake of time. But I think since it is a talk of masses, you should know that really primary cardiac tumors are rare. In fact, they're, the most frequent tumor is really a metastatic tumor to the heart. But of the benign tumors, of the primary tumors, 70 to 75% are benign, whereas only 25 to 30% are malignant. And vast majority of those are the angiosarcomas. Most common tumor to the heart, 20 to 40 times more prevalent than a primary cardiac tumor, is a metastatic tumor. And these can come from, direct invasion, hematological spread, through the lymphatic system, and they can be anywhere. They can be in the heart, they can be in the pericardium, in the myocardium, and obviously these portray grave prognosis. We have typical locations for tumors. I think the slide is very helpful in that, based on what the location is can also be helpful tip-offs along with the tissue characteristics. So that's one thing to keep in mind as well. And then these are a bunch of cases showing different types of tumor, which, we can do at some other time.
Let's go through this real quick. Obviously, the main role of CT is after you've done your echo and MRI, if you have any questions, you do the CT. That's the bottom line, right? I mean, you can, but I believe there may be a couple scenarios you could go to CT directly. Anyway, so how do we evaluate cardiac masses in CT? We base our tissue characterization on Huntsville unit on the right. So you can see, I mean, this is a very crude separation of different tissue characteristics. But bottom line, we can see fat very well because there's nothing really, no other type of tissue will have negative Huntsville unit. And we can see calcium very well because very few structure had Huntsville unit more than 200 without contrast, especially. So technically, you can get a lot of information by doing non-contrast CT. It's actually better without contrast, and you can determine if the mass is made of fat or calcium. So that's probably the major strength of CT. Differentiate fat and calcium from other soft tissue. And we can do perfusion. It's not routinely done, but with a new scanner, I think you open up the opportunity to determine the perfusion of the mass. And same thing with MRI and echo. I mean, the associated finding is very useful in determining if the mass is a clot, is a benign tumor, or possibly a malignant tumor. And there's not much publication. I would say up until a year ago, I don't think there's any specific publication on CT evaluation of the cardiac mass using multi-detector CT. You can see the difference here. Most of the publication you see, or even case report in the radiology literature, based on non-gated CT and spatial resolution is not as good and is static versus you can see here. I mean, this is a very different way of evaluating cardiac mass. So essentially, if you want to evaluate cardiac mass, I really should do a gated cardiac CT. So I'm going to skip some of this because this is not that relevant, just interest. It's very slow. As Dr. Q mentioned earlier, this is a rather interesting case. Again, the associated finding is very helpful in determining the nature of the cardiac mass. You can see here is the patient who come in with heart failure symptoms, and you can see an echo. Let me see. Echo shows possible apical clot, and it was confirmed. And you can see not only there's clot, I mean, there's also calcification, which is very indicative of this is an old clot and it's associated apical wall motion abnormality. What's interesting, this patient did not have significant coronary disease, so we opened up the potential differential of what could have caused this apical wall motion abnormality. Okay, this is a patient with atrial fibrillation and our TIA. As you can see, there's a mass here, lateral wall of left atrium. I think we had a recent case similar to that presented in Valve Conference. Basically, based on the location, the patient with a very large atrium, coronary atrial fibrillation, lack of minimal, almost no contrast intake, this most likely is a clot. Unfortunately, there's no confirmation because the patient also found to have a mass in the lung, and I think she went home without any further surgical exploration, so it just went home with anticoagulation. So basically, the clot is usually homogeneous, hypodense, and no contrast uptake. And obviously, you can do the delay imaging, and it shouldn't, like, same thing with MRI, it shouldn't have any contrast uptake. And we see this all the time with, obviously, left atrial appendage is where there's a lot of clot form, and especially with a neural occluder procedure, it's not uncommon. Actually, we see quite a few cases of clot after the procedure. And this is just an interesting case of a clot in transit. I see that in CT. Okay. And dual energies will be very interesting for perfusion. You can see this is a case of a kidney mass. So you can see there's a mass here. There's a mass here. And most likely this looks like a cyst, and this could be kind of indeterminate. And with dual energy, you can create what we call iodine map. So this is a virtual process images. So you can see this structure here. Basically, there's no signal whatsoever. So basically, there's no iodine, no perfusion whatsoever. So this is a cyst. However, on the other side, you can see there was a signal. So there's a contrast uptake. So you know it's a renal mass. Obviously, you can't tell just by looking at it if it's malignant or benign, but at least you can tell if it's a contrast uptake or not. That open up the possibility of more study and research down the line. Okay. So what do you guys think it is? Eric?
Like a left atrial mass, it's like flopping into the mitral valve.
Yeah. So, most likely is a myxoma, as Dr. Nabi mentioned. You can kind of have some idea by looking at its location and insertion site. What CT give you is just, a little more anatomical detail in this sense, determine exactly where the insertion site is, okay? So this is, what's interesting, I think some of you guys in this case, so this is when she showed up with TIA, with a mass, or we did a CT. I can see what later determined to be a myxoma. Interesting, 2 years ago, she came over here for chest pain. The coronary CTA was normal, sent home. We went back and looked at the interatrial septum. So is it the nidus or initial, it's almost identical where the identical location. So interesting. So next time you see it, I might not just say fat. I might recommend a CT every year to monitor. But I think it's interesting. I don't think Dr. Riordan still need to give me the picture, but I think it's interesting. I haven't seen anything say that myxoma could grow in 2 years, I guess. I don't know any one of you guys seen cases. I mean, I think it's quite interesting. Okay, let's see. Let's keep going. Okay, this is just another case with lipoma. You can see, unfortunately, it doesn't project well. You can see extensive lipoma, involving right side and the left side. And you can see it's very hypodense, almost close to, it's a negative. Huntsville union, I think, minus 84. So this is fat, confirmed by surgery. And malignant tumor, again, it's very, we cannot diagnose this. We cannot give you a histological diagnosis, but again, based on the different feature, extra, based on cardiac and extracardiac involvement, you can say it's probably most likely a malignant tumor. But so especially one of the things that been looked at in the radiology literature is that pericardial effusion and extracardiac involvement is probably the most specific feature suggestive of malignant tumor metastasis, which kind of makes sense. Okay, so this is a couple of interesting cases, which I think CT has probably a significant major role, if not to be a first line of diagnostic tool. After echo, if you suspect, like in this case, this is a vascular structure. I know it's kind of off axis, but this is kind of lowish parasternal lung. You can see there's a mass compressing where the aortic groove is supposed to be. So you kind of suspect this could be a sinus valsalva aneurysm. So this is a guy with a chronic venous stasis and lower extremity, dyspnea exertion, and you can see the mass and the communication between probably aorta with this mass. So you can what's cool with CT is give you very detailed anatomical features, and in this case it show that we know it's most likely a sinus valsalva aneurysm, but the relationship with other cardiac structures, specifically in this case the right coronary, is important. And this case was done for coronary assessment before the surgery. Imagine if you, I don't know, Eric, how confident for you to engage this coronary using regular catheter? I mean, it may be not that hard, but again, it's always good to know before you go in. And also for the surgeon, before he goes in, you want to know the relationship of the structure you're going to resect with the coronary, so he can take extra precaution. And this is just stasis, okay? Obviously, there's only one entry point, there's no exit point, so there's a lot of. So this is a picture and 3D rendering. I think this is probably one of the most interesting cases I've seen for cardiac mass. So this is a patient with cabbage and coming with angina. And this is actually I know it's flipped, but this is left atrium. So you see a mass in the left atrium. Nick, if you don't remember this case, what do you think this is? It's hard to tell, right? I mean, it could be anything, right? Patient is not in AFib, so make the clot less likely, and the atrium is not too big. What's interesting, look at the color. So this is MR, right? But look at this. This pictures are flipped, I'm sorry, okay? So this is a different angle, angulation. And you can see there's some flow signal, right? I mean, it looks like it's intarsally because you don't see the MR signal when these signals appear. Do you agree, Nick? Okay, so it's probably diastolic phase. So that kind of, okay, so it could be a structure in communication with the left atrium, and there's flow, and it's doing diastole. Okay, so maybe a vascular structure, probably arterial, and probably coronary. So patient had bypass surgery, you can see, so the diagnosis was a giant aneurysm of the bypass graft to the OM. It was essentially like the cubitus compress the left atrium and create a fistula between the aneurysm. So again, I mean, the strength of CT here is allow you to see the anatomical detail of this communication. It'd be very hard to detect it with any other technology. And again, make the surgeon's job a little bit easier when he goes in and resect this. So anyway. And the other couple of things that I think we're going to present this Thursday, pericardial cyst. It's very common, you know, by location and the nature of homogeneous appearance and the Huntsville unit close to water density. Most likely, this is just this is unusual case of very big pericardial cyst. Okay. This MRI can give you obviously diagnosis as well, and you know, actually it's quite common if you pay attention. When you read calcium score, I think maybe once every couple of months you run into this case, and location could be everywhere, as you can see here. Okay. That's all I have. So essentially, you know, I think if you have a cardiac mass, and you don't know if it's fat, if you don't know if it's calcium after MR because of image quality, a patient contraindication or not, I think a non-contrast CT is a way to go. Super easy, quick to do, and you can tell with very, you know, good confidence if the structure is lipomatous or calcific. And if you have somebody who you suspect vascular mass inside the heart or close to the heart, it's reasonable to do a CT first because it gives you diagnosis and also probably give you a little bit more anatomical detail. But anything else, you probably want to go with CMR, even with clot even.